Afternoon, everybody. I am Rihab Abdel Fattah, Clinical Investigation Consultant and the VDH IPC Team Lead with the Healthcare Associated Infections and Antimicrobial Resistant Program, or HAI-AR program at Virginia Department of Health. Welcome to today's webinar, CDC and CMS COVID-19 Updated Guidance for Infection Prevention in Healthcare Facilities. A couple of housekeeping items. First, after today's presentation, there will be a Q&A session. You may type and submit your questions in the chat box, and we will get to it after the presentation. This presentation is recorded, and the slides and the recording will be available on the HAI external website in a few days. During our presentation today, presenters will talk about updated CDC infection prevention and control guidance after the end of federal COVID-19 public health emergency, what has changed, what recommendations remain the same for healthcare facilities, including nursing homes and other congregate settings like ALFs. Presenters will talk about COVID-19 surveillance and reporting requirements in Virginia, as well as CMS final rule for staff vaccination requirements in healthcare facilities, in addition to residents and staff testing requirements for COVID-19 in skilled nursing facilities. Also, CMS updated guidance regarding CLIA amendments, post-public health emergency, and nursing home visitations guidance. Now, I would like to welcome our presenters for today's webinar, Ms. Andrea Chapman and Ms. Carolyn Kiefer. Both are regional IP coordinators with the HAI-AR program at VDH. It's my pleasure now to turn it over to Carolyn first. Carolyn, please proceed.
Thanks, Rihab. Next slide, please. Well, good afternoon, everyone. Thank you so much for joining us for a high-level review of the COVID-19 infection prevention and control recommendations that were updated as a result of the end of the federal COVID-19 public health emergency on May 11, 2023. Updated documents include the CDC's COVID-19 IPC recommendations for healthcare personnel and CMS's guidance for the expiration of the COVID-19 PHE and the nursing home visitation guidance. Next slide. There were no changes to note in the COVID-19 healthcare guidance for managing healthcare personnel with SARS-CoV-2 infection or exposure or mitigating staffing shortages. These documents were last updated September 2022. Next slide. Overall, changes to note for the IPC guidance addressed circumstances when the use of source control is recommended, the removal of the recommendation for admission testing and routine testing in nursing homes, and also FAQs were added to the healthcare IPC recommendations page instead of being on a separate page. Next slide. What has not changed for the COVID-19 healthcare IPC recommendations includes the processes to identify and manage individuals with suspected or confirmed SARS-CoV-2 infection, testing recommendations following an exposure or during an outbreak, and the duration of transmission-based precautions. Next slide. Additionally, there were no changes to the recommendations for personal protective equipment when caring for a patient or resident with suspected or confirmed COVID-19, patient or resident placement, and healthcare personnel work restrictions following an exposure. Next slide. Now we will cover source control in healthcare facilities, what has not changed and what has changed. Next slide. What has not changed for source control are the recommendations for individuals in healthcare settings who have suspected or confirmed COVID-19 or other respiratory infection. Those who have had close contact or a higher risk exposure with someone with COVID-19 for 10 days after the exposure, or reside or work on a unit or area of the facility experiencing a SARS-CoV-2 outbreak. Universal use of source control could be discontinued once the outbreak is considered over when no new cases have been identified for 14 days. Outside these instances, even when a facility does not require masking for source control, individuals should be allowed to use a mask or respirator based on personal preference, informed by the perceived level of risk for infection based on their recent activities and their potential for developing severe disease if they are exposed. Next slide. Since the end of the federal COVID-19 PHE, CDC no longer receives data needed to publish community transmission levels for SARS-CoV-2. This metric informs CDC's recommendations for broader use of source control in healthcare facilities. CDC emphasizes that source control is a core IPC practice and remains an important intervention during periods of higher respiratory virus transmission. Without the community transmission metric, healthcare facilities should identify local metrics that could reflect increasing community respiratory viral activity to determine when broader use of source control in the facility might be warranted. Facilities could choose to use source control facility-wide or based on a facility risk assessment, which could be targeted towards higher risk areas like emergency departments or urgent cares, or patient populations like patients with moderate to severe immunocompromise during periods of higher levels of community SARS-CoV-2 or other respiratory virus transmission. We will cover additional risk assessment criteria in the following slides. Or the recommendation for source control use as recommended by public health has not changed, but the metric of reference changed to the COVID-19 hospital admission levels available on the CDC's COVID-19 data tracker. Next slide. The overall benefit of broader masking is likely to be the greatest for patients at higher risk for severe outcomes from respiratory virus infection and during periods of higher respiratory virus transmission in the community. When facilities are determining the use of broader masking with their risk assessment and plans, there are essential items to consider. Identification of early risk recognition, areas or locations of high risk exposure, and other respiratory viruses as well, such as influenza. Communication and coordination are essential internal and external to the healthcare facility. Healthcare facilities are connected regardless of the facility type, so it is vital to communicate and coordinate with other facilities in the local community. Internally, it is important for healthcare facilities to keep their staff informed and engaged, providing training and sharing rationale for changes. Additionally, policy and procedures should be updated, and then auditing and monitoring implementation and compliance processes should also occur. Next slide. Specific criteria facilities should consider incorporating in the risk assessment when determining how and when to implement broader masking use could include the types of patients cared for in the facility. Facilities might tier their interventions based on the population they serve. For example, consider a lower threshold for action in areas of the facility, primarily caring for patients at highest risk for severe outcomes, such as cancer clinics, transplant units, or in areas more likely to provide care for patients with a respiratory infection, such as urgent cares or the emergency department. Except when experiencing an outbreak within the facility, facilities with residents or patients that generally do not leave the facility might consider implementing masking only for staff and visitors. Stakeholder input. Reviewing plans with stakeholders can help a facility determine practices that will be more broadly supported. Stakeholders could include patient and family groups, healthcare personnel, and the local health department. Plans of other facilities. Some jurisdictions might consider a coordinated approach, such as in a healthcare coalition for all facilities in the jurisdiction that share patients. And available data. Facilities and jurisdictions might have access to more granular data to help guide efforts locally. This could be internal surveillance data such as influenza activity, healthcare-associated COVID-19 infections, or COVID-like illness amongst staff. For external data, we will cover some metrics on the following slides. Next slide. Without the community transmission levels metric, healthcare facilities should identify local metrics that could reflect increasing community respiratory viral activity for using to guide the broader use of source control in the facility. CDC is in the early stages of developing metrics that could be used to guide when to implement the select infection prevention and control practices for multiple respiratory viruses. But they note that facilities may consider masking during the typical respiratory virus season, which is approximately October through April, or they could also follow the trends for the several respiratory viruses currently available for use. A SARS-CoV-2 specific metric is the hospital admission data. This is published weekly and is available at the county level. Per CDC, hospital admissions are a good marker of the COVID-19 transmission in the community. Additional national data measures that address other respiratory viruses and include Virginia data are the National Emergency Department visits for COVID-19, influenza, and RSV. This can be used to inform when respiratory virus season is beginning or ending. And the ILI net, which provides more granular information on estimates of outpatient respiratory illness visits and compares state by state. Next slide. Virginia-specific data that is available includes the COVID-19 dashboards. This includes the COVID-like illness visits to EDs or urgent care facilities. This is by district or locality and is an accurate picture of disease in the community for the reported week. COVID-19 associated deaths is currently available by district on the weekly health district case data dashboard. Default on the dashboard is case counts, so you have to filter on deaths. And wastewater surveillance is by region, but is not as sensitive as we have data for only 36 sites. And lastly, the influenza-like illness, VDH flu surveillance data, which is by region. Next slide. For universal use of PPE, what has not changed is the recommendation for PPE when SARS-CoV-2 infection is not suspected in a patient presenting for care based on symptom and exposure history. Healthcare personnel should continue to follow standard precautions for all patients. Also, transmission-based precautions might be warranted based on the individual's suspected diagnosis. Next slide. We all know that as transmission of SARS-CoV-2 in the community increases, the potential for encountering asymptomatic or pre-symptomatic patients with SARS-CoV-2 infection also increases. In turn, facilities should consider broadening the use of PPE for healthcare personnel, such as N95 respirators for all aerosol generating procedures, or the use of eye protection during all patient care encounters. What has changed is that universal PPE use was previously guided by community transmission levels. Now the metrics facilities may use to inform the broader use of PPE are the COVID-19 specific metrics, which we've outlined on slides 12 through 13. Next slide. Now I will hand it off to my colleague, Andrea Chapman, who will cover specific guidance for nursing homes, congregate settings, COVID-19 surveillance, and CMS updates. Andrea?
Thanks, Carolyn. Next slide, please. One of the recommendations that has changed for nursing home admissions is that admission testing is at the discretion of the facility as it is for other healthcare settings. Pros and cons of screening testing are described in the CDC guidance, and we'll share some more details about that on the next slide. What has not changed for nursing home admissions is that quarantine or empiric transmission-based precautions is generally not necessary for admissions or readmissions or for residents who leave the facility for less than 24 hours if the resident is asymptomatic. Situations where quarantine can be considered are described in the guidance section for duration of empiric transmission-based precautions for asymptomatic patients following close contact with someone with SARS-CoV-2 infection in a CDC guidance. Next slide, please. As mentioned on the prior slide, there are some pros and cons to screening on admission. The yield of screening testing for identifying asymptomatic infection is likely lower when performed on those in areas with lower levels of SARS-CoV-2 community transmission. However, these results might continue to be useful in some situations, such as when performing higher risk procedures or for healthcare personnel who are caring for patients who are moderately to severely immunocompromised. This can help inform the type of infection control measures used, such as room assignment or cohorting, or decision-making for type of personal protective equipment. And this can also help prevent unprotected exposure. If implementing a screening testing program, decisions for testing should not be based on the vaccination status of the individual being screened. To provide the greatest assurance that someone does not have SARS-CoV-2 infection, if using an antigen test instead of a nucleic acid amplification test, facilities should use 3 tests spaced 48 hours apart in line with FDA recommendations. Next slide, please. Most of our updates today are for healthcare settings, but I do want to take a moment to review how the guidance has changed for congregate settings. Next slide, please. Congregate settings are facilities that serve unrelated people who live in close proximity and share at least one common room. And this can include group or personal care homes, assisted living facilities, and other similar settings. As with previous recommendations, healthcare services delivered in these settings should be informed by CDC's infection prevention and control recommendations. What is different is that now COVID-19 hospital admission levels should inform general operations. At all levels, these settings are recommended to have their residents and staff stay up to date on vaccination, focus on ventilation improvements, avoid contact with people who have suspected or confirmed COVID-19, follow recommendations for isolation if you have suspected or confirmed COVID-19, follow recommendations for what to do if you're exposed to someone with COVID, and if you're at high risk for getting very sick, talk to a healthcare provider about additional prevention actions. If the hospital admission level for the county is medium or high, if an individual is at high risk for getting very sick, the recommendation is to wear a high quality mask or N95 respirator when indoors in public. And if there's household or social contact with someone at high risk for getting very sick, consider self-testing before contact and consider wearing a high quality mask when indoors. And then lastly, if hospital admission level is high, all are recommended to wear a high quality mask or respirator. And if you as an individual are at high risk for getting very sick, consider avoiding non-essential indoor activities in public. Next slide, please. There have been some recent changes to COVID-19 surveillance strategies and reporting requirements to the National Healthcare Safety Network. So we will review those in the next portion of the presentation. Next slide, please. As we come out of the public health emergency and shift focus away from counting individual cases, the VDH COVID-19 surveillance approach is changing. Our current priorities are summarized on this slide, and they are to track trends and intensity of SARS-CoV-2 transmission, We're doing this by monitoring early warning indicators, such as emergency department visits and wastewater surveillance. We are evaluating severity of COVID-19 in the spectrum of illness, and we are prioritizing hospitalizations and deaths in this approach. We are monitoring the impact of disease and interventions on health equity. Evaluating projects to better describe the impacts of long COVID is an example of a focus here. We are also continuing to conduct and advance SARS-CoV-2 genomic surveillance. We will continue to monitor variants and conduct sequencing. On our external website, we regularly publish latest data on variants and encourage you to check that out. We also share surveillance data and adapt risk communication. We continue to maintain data dashboards, as Carolyn already alluded to, and display data metrics that are valuable. Next slide, please. In terms of outbreak reporting requirements, certain facilities or programs, such as residential or day programs, services or facilities licensed or operated by any agency of the Commonwealth, schools, childcare centers, and summer camps, are required to report the presence or suspected presence of an outbreak to the local health department. In most of these settings, the threshold for reporting a suspected outbreak is when there are 2 or more cases. And VDH has a really nice outbreak reporting portal to report outbreaks online. So hope facilities are using that portal. However, in nursing homes, an outbreak investigation should be initiated when there is a single new case of COVID-19 in a resident or staff member. And reporting to the local health department should occur at this time for nursing homes. Note that an outbreak investigation would not be triggered when a resident with known COVID-19 is admitted directly into transmission-based precautions, or when a resident is known to have close contact with someone with COVID-19 and is admitted directly into transmission-based precautions and develops COVID before transmission-based precautions are discontinued. Also, in the nursing home setting, the Office of Licensure and Certification requests voluntary reporting of outbreaks, not individual cases, from those nursing homes via a facility report incident form. Next slide, please. The Virginia regulations for disease reporting and control were updated earlier this year. Physicians and directors of medical care facilities are required to report to the health department not only when a person who is infected with or who is suspected of having COVID-19 is treated or examined, but also if the person is hospitalized or admitted into an intensive care unit. This report should be sent electronically within 3 days of the suspicion or confirmation of disease using either VDH's online confidential morbidity report portal or an electronic case reporting mechanism. Note that when the regulations were updated, the required data elements also were updated. So this adds variables like ethnicity and phone number, in addition to what was already required, such as race and other demographic information. Next slide, please. Directors of laboratories and other entities that hold a Clinical Laboratory Improvement Amendment, or CLIA, certificate of waiver, and this includes pharmacists, they are required to report positive SARS-CoV-2 tests, PCR tests or antigen tests to VDH. The report, similarly to what we said for physicians and medical facilities, must be submitted electronically within 3 days, but this can be either through the point of care test reporting portal or through electronic laboratory reporting. Negative SARS-CoV-2 tests are no longer required to be reported. And Similar note that required data elements have also been updated. And now that we've reviewed the state reporting requirements for outbreaks in individual cases, next we'll review what has changed regarding reporting to the National Healthcare Safety Network. Next slide. In hospitals, two primary changes will be implemented for the COVID-19 hospital data reporting guidance post the end of the COVID public health emergency. There will be fewer data elements required to be reported, and several fields will be made optional. Reporting cadence has changed from daily to weekly, where values from the prior Sunday to Saturday are to be reported by the following Tuesday. We are currently in the middle of the implementation timeline shown on the slide, where next Tuesday, the 20th of June, will be the first Tuesday that can be used for weekly submission. And these reporting requirements will be in effect through April 30th, 2024. Next slide. After the COVID-19 public health emergency expiration on May 11th, dialysis facilities are no longer required by CMS to report COVID-19 cases and deaths among patients and staff to NHSN. However, the NHSN dialysis COVID-19 module remains available for voluntary reporting by individual facilities and group users. Reporting of COVID vaccination among patients and staff remains required after that May 11th date. Dialysis facilities should continue reporting to NHSN patient COVID-19 vaccination and healthcare personnel COVID vaccination modules. However, dialysis facilities only need to report these vaccination data for the last week of each month. Next slide, please. In long-term care facilities, those that are CMS certified still have required reporting to the long-term care facility COVID-19 module surveillance pathways and the COVID-19 vaccination module after the end of the public health emergency. The COVID-19 module surveillance reporting pathways has some updates, and this has reduced certain required fields. It's added a hospitalization field. So there are some notes on the slide about those changes. CDC has recently offered training on these changes in much more detail than we're going into right now. And those slides are on the NHSN website if you'd like more information about that. Please note that the reporting requirements for the surveillance pathways module are in effect through the end of calendar year 2024. But as we'll talk about more in the CMS update section, the staff and resident vaccination reporting requirements are going to be permanent. Next slide, please. In the next section of the presentation, we'll highlight some of the memos and rules that CMS has published in recent weeks. On the next slide, the first CMS update to note is a final rule that was published last week and goes into effect 60 days later on August 4th. As with a lot of CMS communications, this is a long one, very dense, so trying to pull out some of the highlights for you on this slide. For long-term care specifically, this rule deletes the staff and resident testing requirements that were only effective through the end of the public health emergency. For numerous healthcare settings, it withdraws the requirement to have all staff vaccinated for COVID-19 or receive a medical exemption. And many of you may have a question about how this is going to be enforced between now and August when the final rule goes into effect. For CMS, staff vaccination provisions will not be enforced due to the fact that facilities are no longer operating under the public health emergency circumstances. And this is a lower priority enforcement given the limited time remaining before the final rule becomes effective. And just a side note that although vaccination will no longer be required by CMS, staff vaccination may be a quality reporting measure in the future. And we continue to remind everyone that the strongest protection from COVID-19 is the vaccine. And therefore, we urge everyone to stay up to date with your COVID-19 vaccines. This final rule also finalizes the educate and offer rule. This maintains requirements for long-term care facilities and intermediate care facilities for individuals with intellectual disabilities to educate staff and residents about, as well as offer, the COVID-19 vaccine. This also maintains the requirement to report resident and staff COVID vaccination status to the National Healthcare Safety Network, as noted in a prior slide. Next slide, please. Another recent memo summarized some changes to the CLIA guidance following the end of the COVID public health emergency. Back in December of 2020, CMS issued guidance explaining that it was temporarily allowing laboratories to use FDA-authorized SARS-CoV-2 molecular and antigen point-of-care tests on asymptomatic individuals. And this was outside of the test authorization. So as of the end of the public health emergency, all CLIA certified laboratories are required to follow the manufacturer's instructions for use, including the intended use for SARS-CoV-2 testing. And during the public health emergency, CMS allowed laboratories to use expired reagents due to some reagent supply problems. And so following the end of the public health emergency, CMS has determined that laboratories will no longer be able to do this and should use reagents that are within their expiration. Use of expired reagents would be considered a test modification and would require the laboratory to establish performance specifications. In addition, the test would default to high complexity. So this is a return to pre-public health emergency regulatory requirements. The memo also stated there is no longer a CMS requirement to report SARS-CoV-2 results. However, as we talked about a few minutes ago, there is still a state requirement. So all CLIA certified labs should continue to report positive results. Next slide, please. The memo described on this slide, guidance for the expiration of the COVID-19 public health emergency, outlines information for multiple types of healthcare facilities, but we're pointing out a few nuggets that are applicable to skilled nursing facilities and/or nursing facilities. Some requirements that ended with the public health emergency include routine testing of residents and staff for COVID-19 infection, and certain requirements around grouping or cohorting of residents with respiratory illness symptoms and/or a confirmed COVID diagnosis from residents who are asymptomatic or negative. And as mentioned in the surveillance section of the presentation, COVID-19 vaccination status of residents and staff is a permanent requirement, and the weekly COVID-19 information will continue being reported through the end of 2024. And next slide is my last slide about CMS updates. And this is about some revisions to nursing home visitation guidance. And there were just some minor updates here. Facilities are still expected to adhere to infection prevention and control recommendations during visitation. And the memo continues to refer to accepted national standards, including things like the CDC recommendations. The memo specifically mentions posting visual alerts at the entrance and in strategic places to include instructions about current infection prevention recommendations, like when to use source control. Resident and staff testing should follow nationally accepted standards. Visitors are encouraged to stay up to date with vaccination. And if visiting during an outbreak, the visit should ideally occur in the residence room with both the resident and visitor wearing source control if able to be tolerated, and physical distancing also occurring if possible. Moving on to the next slide, sharing some resources and references for more detail. The next slide has some updated resources from VDH. I will mention that for long-term care settings, the COVID long-term care task force page is being phased out in the near future, but all of the COVID infection prevention resources for the long-term care setting are currently housed on the VDH infection prevention long-term care settings webpage. So we're not going to be losing any of those resources. We have revised the 4 documents listed on the slide for the nursing home setting to reflect the latest CDC and CMS guidance changes that we've talked about today. And the COVID-19 FAQs continue to be updated as well. Next slide. More VDH surveillance resources are here for you on this slide. And we have some colleagues from the Division of Surveillance and Investigation on the call today if there are any questions about surveillance. Attendees from local health departments, please note that there have been some updates to the COVID disease control manual chapter in both the outbreak subsection and the long-term care subsection. And next slide, please. This last slide of updated resources has links to the CDC and CMS guidance documents we've talked about today. I also want to point out that the CDC Clinician Outreach and Communication Activity, or COCA, calls continue to be a good way to get information about COVID and other public health topics. So encourage you to check those out when applicable. And with that, we have wrapped up our slide presentation, and we'll be transitioning to the Q&A part of today's webinar. Thank you so much for joining us.
Thanks, Andrea and Carolyn. And I think we have good time for question and answer. I will start with the questions in the chat box. Please feel free to keep adding your questions in the chat box or unmute and talk live. We have representatives from Office of Licensure and Certification, as well as a representative from DSI or Division of Surveillance and Investigation to answer any questions related to CMS, either CMS or surveillance data elements. I will start with the question in the chat from Erin. Can we continue to require prospective staff to show proof of COVID-19 vaccination? Anyone from Office of Licensure and Certification would like to answer this question?
Good afternoon. This is Katarina Rampag from the Office of Licensure and Certification. You may request the proof as long as your facility policy states so. It is, the reinforcement of the rule for vaccination is no longer surveyed for, but if you have your internal policy, then you can do it.
Thank you, Alicia. Second question is regarding from Dr. Rosheim, and it's regarding wastewater surveillance and any specific actions related to that. I see Heather answer the question in the chat, and I agree with Heather. I would like to add that wastewater surveillance here in Virginia, it's sampled like from only 36 localities and sampled twice a week. So it's definitely a good indicator for or early warning for COVID transmission in the community, in that local community. But also it can, it needs to be used with other data elements, surveillance data element like hospitalization rate and emergency room visits, this type to get, an idea, a complete idea about that, what's happening. Over time, that can give us an idea, wastewater surveillance can give us idea about the trend. And I think that's, we have, I think, a dashboard for wastewater that has been, available since May this year. So thank you, Heather, for answering that question. Anything else you would like to add?
Good afternoon, Rehab. I am going to go ahead and put in 2 dashboards into the chat for everyone. Again, a lot of this information is found in the slides, but I'll go ahead and put it here for easy access. But yes, I do think it's important just to keep in mind that it's best to look at the overall trends that are happening. So I'm going to go ahead and include that dashboard here into the chat. Thanks so much.
Thanks, Heather. I see the next question from Wendy, and it's also regarding staff vaccination or proof of staff vaccination. And I think our colleague from Office of Licensure and Certification answered that question. Wendy, do you have anything specific extra you would like to explore before we move to the next question? Or that would be enough? Okay, the next question in the chat, is there any information on the ETS mandate training to continue? Michelle, would you like to come off mute and maybe explain your question more?
Yes. Hi, Rehab. Well, I'm just asking because we're a state facility, and I know that when COVID hit, there was an ETS mandate out that everybody had to make sure that they were educated on COVID and per facility. So I wanted to know, they rescinded the ETS, but they didn't say that it was altogether gone. And I've looked at everything on OSHA and nothing is clear. So I was trying to figure out, do we still need to continue to have this mandated training, or can we just do our own COVID training, per the current mandates that, the directives that are there? Because I don't want to be out of compliance with OSHA, with so many things being lifted, but that's not clear. And I wanted to know if anybody from VDH or, surveillance, anybody knows anything about that, because it's not clear on the website for OSHA.
Thank you. Anyone from DSI would like to answer that question?
Good afternoon, Rehab. I would have to look more into that. I do not have that answer for you, but would be happy to look into it further.
Thank you. I really would appreciate that.
Absolutely. Thanks so much.
Thank you. In the chat, I missed a question regarding from David, and the question reads, is there a specific guidance change for acute care hospitals and inpatient psych facilities getting rid of admission COVID screening? I can start, but I open it as well to other folks from VDH or ALC to answer that question. So The updated guidance from CDC and VDH as well is healthcare facilities to develop their plan regarding their mask mandate or broad use of source control, as well as other IPC practices, including testing. The testing on admission is mainly up to the facility. It's a decision the facility might take based on multiple factors. The surveillance data elements are part of that. So, you know, what's happening in the local community, what other facilities in your jurisdiction are doing. And also the type of patient population, if certain areas in the facility have more of immunocompromised patients, or it has a high traffic like emergency rooms where the exposure is high. So the risk assessment of exposure, it's and any IPC recommendation related to that is up to the facility to develop their plan, share that with their staff, train them on it. When it comes to screening for COVID symptoms, recent exposure, that's still being required for facilities to do that for their staff, for their patients and visitors. I will stop here and see if Andrea or Carolyn would like to add to that or maybe expand on some points.
Thanks, Rehab. And so as emphasized with the current CDC updates is that, you know, as a core IPC practice to have those processes in place to identify and manage individuals with suspected or confirmed infectious illness, and to have that early detection and management. So we have the initial points of entry at facilities and at the time of admission. So that is emphasized in the CDC core IPC guidance.
Thanks, Carolyn. Moving on, just to make sure that everyone, because I see, you know, more people adding questions in the chat. If for any reason we couldn't get to your question because of the end of the webinar time, we will make sure to get back to you. If we didn't answer your question live, we will make sure to get back to you with answer for your question via email. So please keep adding your questions. And next question in the chat is from Mary. Please clarify nursing home reporting of COVID to OLC via FRI. Who's from OLC would like to answer that?
Hi, Mary. It's Kim Beasley. Can you hear me?
Yes. Hi, Kim.
Hi. So what we're asking here is it's a request. So as you know, the regulatory requirement is actually for facilities to report outbreaks to their local health department. We do get those notifications from local health departments. Sometimes there's a little bit of a lag time there. So during COVID, you know, the request started for reporting to OLC, and we've just kind of kept that request in place, but it's just that it's a request. So I'm not sure if that answers your question or if you have anything additional.
Thank you, Kim.
Sure.
The real question is, do facilities have fairly consistently been reporting, I believe, via FRIs. But the question really is, if there is only one case, do we report the one case, or do we use the CMS definition of outbreak, or at how many cases would we expect to see that should be reported?
Yeah, I think Rehab mentioned we're not expecting a report of every individual case.
Okay. All right.
Initially during COVID, yes, you know, when things first got started, that was the request, but not now.
Thank you so much.
And may I add, this is Dr. Gwaltney, may I add that yes, the request it's a request, but for Fry, if it's an initial COVID outbreak, then yes, but anything after that, you could send the supervisors an email because that's what most of the facilities have been doing.
Thank you.
If it's an initial outbreak, then yes, you can send in the Fry, and then anything after that, we're just asking for an email. You don't have to, but that's just out of courtesy.
Thank you so much.
You're welcome.
Great. Thank you so much. Next question in the chat, it's from Natalie. Is daily screening of residents in long-term care facilities for symptoms of respiratory illnesses still required or recommended? I can speak to the recommended part as it's as Carolyn mentioned, it's maybe a core IPC practice to screen people for not only COVID, but other respiratory viruses like flu and RSV. So it's a good practice. I can say it's a core IPC practice to screen resident for signs and symptoms for early detection and taking the appropriate IPC recommendation based on that. For the required part, so from VDH point of view, it's a good practice, so it's recommended, but the requirement part, I will leave that up to maybe folks from ALC, or if anyone from DSI would like to address that, because it depends also on the local health district requirement. So can we start with ALC if this is still required?
Well, and this is Andrea from the HIA program. What we have said in the past, and this has not changed with the latest guidance, is that all healthcare facilities, including long-term care facilities, should have a mechanism in place to promptly identify if a patient or resident has signs and symptoms of any communicable disease. But the mechanism and frequency of monitoring asymptomatic individuals is at the discretion of the facility.
Thanks, Andrea. Anything else to add, maybe from ALC or DSI regarding the required part?
Hi, Rehab. This is Heather Harmonslin with the COVID-19 unit in DSI. We would agree with what Andrea had said in her statement. I think it's just good practice. Thank you so much.
Thanks, Heather. Next question in the chat, is there, from Samantha, is there any forecasted end to the use of CLIA waivers for COVID testing?
So this is Kim Beasley again. I just want to make sure I understand Samantha's question. So are you asking about the requirement to obtain a CLIA certificate in order to perform COVID testing?
Samantha, please feel free to unmute and explain more.
Hi, good afternoon. More along the lines of if CLIA waivers would ever not cover the ability to COVID test for our facilities, or if the ability for our facilities to receive them would go away.
Oh, okay. So a common mistake is the waiver is not really a waiver. So it's a type of CLIA certificate. So it doesn't exempt you from anything. It's just a level of CLIA certification. So all testing, depending on what level of complexity, does require CLIA certification. So if you want to perform COVID testing, that is going to always require a CLIA certificate, and most of those tests are classified as waived. So that's why you have a CLIA certificate of waiver. Does that help? And that will not go away, that requirement.
Regarding CLIA as well, there is, Kim, while you're still on mute, there is another question from David regarding CLIA. There was a testing compliance requirement, but in CLIA waived facility, we have no indication to test that fits the manufacturer guidelines for rapid antigen testing. So would be out of CMS compliance. David, feel free to come on mute. Off mute if you would like to explain more.
Hi, it's David. Now, currently we have a requirement to test or have a recent test within 24 hours of any incoming patient, which is fine. But now we also have a requirement here in-house to test on days 1, 3, and 5 after admission. Now, there's no indication to test. So without an indication to test, we have to follow the package guidelines for our rapid antigens, which on our CLIA waived, we would be in violation of because we have there's no symptomatic, there's no history of recent COVID. It's simply a testing requirement. Will this go away on 8.4? It's an admission requirement in acute care and psych hospitals.
Is that an in-house admission requirement that you all have established?
There was a CMS guideline that I can't find it in the Federal Register document from 6.5 where that changed. It changed it for long-term care, but I don't see that it's changed it for acute care and psych facilities. So we just assume it's changing since it is LTKC.
I think the information, and someone correct me if I'm wrong, that you went over earlier was for all healthcare facilities, correct?
Yes.
Yeah, okay. So that should apply to you as well. I'm not sure if your psych facility is CMS certified or not, because
We are.
Okay.
We are.
And then, but let's talk a little bit further about if that is a something that would be considered not following the manufacturer's guidelines, because obviously you're aware that takes it to another level.
It pulls it out of my CLIA waived
Yes.
testing, which CMS for 90 days we're not going to enforce, but now we're past that. So
Right. So I'd like to pull in my CLIA staff for that question so we can provide an accurate rather than me trying to guess.
thank you so much.
Yeah, they all happen to be here today, so we'll be able to provide a quick response to you.
Okay, we are at 1. So I'm sorry if we didn't get to your question, but I promise that we will get to all questions that we didn't get to, or that we will check and get back to you to consult someone. I see questions regarding NHSN reporting, expired COVID vaccinations, and any other questions in the chat. We will get to that, and anything that we said, we will check and get back to you. We will do that. Again, the slides and reporting will be available on the HAI external webpage, the education section. in few days for those who haven't attended or would like to go back and review the presentation. I really appreciate your time. Thank you so much for joining us today, and looking forward to more meetings and webinars. Thank you.
Thank you so much. This has been great, Ms. Abdul.
Thank you.
Thank you.
Bye.